measurement, only one measurement here, you would have said, okay, this is still normal, it's a kind of a smallish baby, but it's okay, not too bad. But if you had the previous data, then you would realize that no, although this is normal, this has dropped, and this has dropped significantly, definitely more than 50 percentiles. And so this is definitely FGR. So that is why when an ultrasound person says, okay, please send the baby back for after a month, he's not just trying to make a fast buck. This is actually an important thing to consider, that you should be doing your growth profiles by at least 2 or even more ultrasounds. Doppler, you do an umbilical artery, MCA, you do CPI, you do Ductus Venosus, and you do uterine artery. How many of you have done a Ductus Venosus? Yeah? No? अरे यार आप तो उलमाए दीन हो ना यार आप तो any more? Okay, Ductus Venosus is very, very underutilized. It should be done in every first trimester scan, as I'm sure Fazil is going to tell you. It is a marker that has a 20% association with fetal aneuploidy, with cardiac disease, or a generally poor outcome. So when you're doing your, and actually a first trimester Ductus Venosus is pretty easy to do. It's much easier than a second or third trimester Ductus Venosus. Okay? Right. Umbilical artery Doppler, we all know that it represents placental vascularization. After 20 weeks, you should have a positive diastolic flow. The PI continues to decrease as the pregnancy advances. Decreasing PI means that the diastolic flow component starts to increase. You can use an SD ratio, but a lot of the world uses PI. Personally, I use PI, but your machines are going to give an output which has both SD ratios and PI. Just don't eyeball. Get your numbers. Okay, let's do an experiment here. Normal or abnormal? This one, at the end. Normal or abnormal? Abnormal. We all agree? Okay. Normal or abnormal? Abnormal. Good. Normal or abnormal? How many for normal and how many for abnormal? You are for normal? How many for normal first? Normal, 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 normal. Normal or abnormal? Normal. Okay? Now let us see what the reality is. You see, that is the problem with having an absolute value to define your normals over the whole or over a large portion of fetal age. Now, although the value is 1.32 PI, which a lot of you would say, 1.4 se kam hai, this is normal. Actually, for this age, this value is wrong. And you see, this is the normal chart, and this value is definitely over the 95th centile. So that is the importance of not relying on absolute numbers in anything in fetal ultrasound. We should start using percentiles when we are assessing, analyzing, and reporting our fetal ultrasounds, because a percentile is age specific, right? Ye jo percentile chart hai, you know, this is at 32 weeks, these are the values, and the values have changed by the time you come to 40 weeks. So it doesn't make sense to have one value to serve your whole gestational age. And by the way, these charts, these are very easily available. If you go to FMF website, these are free. You can just put in your numbers there and it will give you, ye sare FMF se liye gaye hain. Okay, when you're doing the umbilical artery Doppler, you must remember that the PI at the placental end is different than the PI at the fetal end. And sometimes this can be quite significant. For example, this is the same patient, and the PI near the fetus is 1.5, and PI near the placenta is 1.14. So that is how dramatic the difference can be. So you need to site your ultrasound gate at the right location. Now, I don't know if you know this, but there is something called Hertel's anastomosis, which connects the two umbilical arteries near the placental. Sometimes you can actually see it if you do a Doppler of that area carefully. And that equalizes the flow in both umbilical arteries. So it doesn't matter if you're using one or the other. But in about 15% of the cases, your umbilical arteries tend to be asymmetrical, and your flow tends to be asymmetrical. So in your cases where you have an abnormal umbilical artery PI, it always makes sense to look at the other umbilical artery also. For example, this is a cross section. One umbilical artery, the other umbilical artery. It is very obvious that one umbilical artery is smaller than the other umbilical artery. Same patient, you put the gate, you have a wide gate that steps on both umbilical arteries, and you have two kinds of Doppler spectra. One by one is 1.33 and 0.69. Okay, so that is how big the difference can be. So if you have a patient with an abnormal umbilical artery, you should always try and look at the other umbilical. It's not difficult at all. दोनों नजर आ रही हैं, एक पे रखा पे दूसरे पे रख लिया. Now, should you use a free loop or a paravesical? I think just for interest, there's a lot of debate on this, because for twins you're already using paravesical because it's difficult to differentiate what fetus a particular loop of cord belongs to. So you're already using paravesical. So it might be more useful or more reproducible if you use paravesical umbilical arteries. SUA, single umbilical artery, it can happen in up to 5% of singleton pregnancies. When this happens, obviously one umbilical artery has to carry all of the blood that usually would have been carried by two umbilical arteries, right? So this umbilical artery dilates, and since more blood is flowing, the PI drops, right? The diastolic flow increases. So if it's an SUA, your PIs might be lower than what the fetal status would actually tell you. But you must remember that SUAs are associated with smallness and FGR. So if you have an SUA, without scaring the patient, you need to explain to them that in some of the cases, your baby might be smaller and we need to monitor this more carefully. And in twins, this adaptive dilatation does not take place. Okay. The umbilical artery Doppler, please remember, is not a very sensitive parameter for placental dysfunction. Actually, about 30% of placental villi need to be lost before your end diastolic flow will reduce. And about 60% of your villi will need to be lost before your end diastolic flow will become absent. And if you have an absent end diastolic flow, this can persist for several days, and it is not a calamity in most cases, and just tells you that you need to be more careful in monitoring the patient. We will talk about what real calamities are. And you must remember that, like we have already discussed, umbilical artery Doppler can be normal in early stages of FGR, and umbilical artery can be abnormal in non-FGR cases, for example, in triploidy or trisomies. Okay. MCA. How many of you do MCA regularly? How many of you do MCA regularly? Okay, there's some evidence to do an MCA regularly, and we're going to talk about that at the end of this lecture. So it basically represents cerebral circulation and the response to hypoxemia. Brain is the critical organ. What are the other critical organs that the baby would like to preserve blood flow to? Adrenals, and of course the heart itself via the coronary arteries. So the baby tries to maintain the blood flow to these vital organs at the expense of other slightly less vital organs. Brain is one of them. It's easily accessible